Hello, everyone, and thank you very much for joining my talk today for the pre-record, one topic of the transplant kidney pancreas symposium of the UCI. Today, I would like to discuss about the dietary intervention to increase living kidney donation and improve long-term outcomes. And I hope that my talk will go along with our theme for the symposium of UCI this year, which is emphasize on living kidney donation. So let's start. So this is a common scenario that we're going to see in the living kidney donor evaluation. You can see for the first one, 25-year-old woman, college student come for living kidney donor evaluation. She would like to donate the kidney to her 60-year-old mother with end-stage kidney disease from diabetes, and she a little bit obese. Next one is a 40-year-old male athlete come to evaluation as well and would like to donate to his 38-year-old brother who has stage 5 chronic kidney disease from hypertension. As you can see, he has a question about can he have a high protein intake or protein powder before and after living kidney donation. Next one, 65-year-old woman with stage 3B chronic kidney disease, presumably secondary to type 2 diabetes, come for living kidney donor evaluation. She would like to donate to her 40-year-old daughter who has end-stage kidney disease from type 1 diabetes. She a little bit frail for this kind of potential donor. And the last one, 70-year-old retired businessman, come for evaluation as well and would like to donate his kidney to a 70-year-old wife who has end-stage kidney disease from hypertension. He has a sedentary lifestyle and obese, as you can see. So this kind of scenario bring up to the discussion about what kind of mortality that this kind of living donor going to have in the long term. On the other hand, or on the flip side, what is the potential risk of develop chronic kidney disease or end-stage kidney disease in the long term for this kind of patient? You can see the arrow is reciprocal. So as a reminder, the benefit of kidney transplantation compared to dialysis. As you can see, this on the yellow part that I highlight is a line 1.0 when the patient who are the reference group on the wait list and on dialysis. As you can see, if our patient receive kidney transplantation, the benefit in terms of lower the mortality going to kick in around 3 to 5 or 3 to 6 months after transplant and stay pretty sustained. And this another data from USRDS, and just to remind everyone, for the patient who stay on dialysis, less than 50% survive in 5 years after initiation of dialysis, compared to our population who receive deceased donor kidney transplant, more than 80% survive. And you can see again, emphasize for the benefit of survival benefit of kidney transplantation. And 3 years when our patient who has end-stage kidney disease on the wait list, where they go. So after 3 years, they may get kidney transplant, and not the small number of the patient after 3 years on the wait list, they die on the wait list. So it's come up to the question, is an organ shortage. This is pretty chronic, persistent, and ongoing. And the question is, and the living donor is one of the strategy to mitigate the shortage of the deceased donor organ. And this slide, even though it's old, but you can see the longer kidney allograft survival benefit of living kidney donor is up to 12, 15 years compared to around 10 years in deceased donor kidney transplantation. However, living kidney donor transplantation is not a risk-free for the donor. As you can see, the benefit is come to the recipient for the living donor kidney transplant. However, the risk is go to our donor. The question is how can we mitigate the risk of our donor to be lower or equal for the recipients? And it's come up with a mitigate the risk of the donation for the pre, peri, and post-donation period. So I would like to share this one, which is I impressed. I saw this one patient in uh, pre-kidney transplant evaluation. He's around 40-year-old, a little bit obese male, and has stage 4 chronic kidney disease from polycystic kidney disease. He cannot find a donor at the beginning. However, he posts this uh, one paragraph or two paragraph on his social media on Facebook. And the one thing that I would like to show you that he said, he would do everything in his power to ensure your kidney would be well taken care of. And finally, after he posts this story on his Facebook, which is called Huge Arcs, he gets around 10 living kidney donor offer within 2 days. Pretty amazing. So this come up to the meat of my talk today. I would like to discuss about the long-term complication of post-living kidney donation, and I will emphasize on management post-donation, how we can mitigate the risk of the long-term kidney donation, and emphasize on dietary intervention to increase living kidney donation and improve long-term outcome. And we'll briefly discuss about future direction and conclusion. So let's start with a long-term complication post-living kidney donation as a review. So let me start with the first question. Which of the following is the long-term risk after living kidney donation compared to general population? Chronic kidney disease, end-stage kidney disease, proteinuria, hypertension, gestational hypertension, preeclampsia, kidney cancer, colon cancer, or all of the above. So let's sit down and thinking by yourself, and I hope that at the end of my talk, everyone get answered correctly. So for our patient who has an acquired solitary kidney, it can come from the renal trauma, has a nephrectomy or living donation or renal cancer. And epidemiology, on average, a nephrectomy for this kind of indication per year. As you can see, our population who receive kidney donation is the majority who has acquired solitary kidney. And the majority of them is around go toward middle age group compared to renal trauma generally in the young age, and renal cancer obviously in the geriatric population. So living donor is great, can increase the number of kidney transplantation, but not everyone is a candidate for living kidney donor. So that's why we have to do a kidney donor evaluation. And again, this slide emphasize again how we gonna balance between increase living kidney donation and to increase the wait list of candidate. So donor evaluation is a balance between risk and benefit of donor as a primary, in my opinion, and benefit of the recipient. So the complication of the living kidney donation, I divide into short-term and long-term. For the short-term, including the surgical-related complication, for example, pain or bleeding, and anesthesia-related complication. For the long-term that I will emphasize on my talk is chronic kidney disease or end-stage kidney disease, proteinuria, hypertension, and pregnancy-induced hypertension or preeclampsia. So let's briefly again about the unilateral nephrectomy. So it can lead to the long-term complication, including chronic kidney disease, proteinuria, and hypertension. And if we focus on the chronic kidney disease, again, in an adult population, the majority have acquired solitary kidney from living donor compared to the young adult, renal trauma, and elderly renal tumor. As you can see, for the young adult, has a long-term risk to develop chronic kidney disease compared to adults and elderly. However, again, the majority of our patients gonna be in adult, which is still in the risk of the long-term complication of chronic kidney disease on their life. So before we move on, let me ask you the second question. Which of the following change potentially occur in living kidney donor? Glomerular hypertrophy, increased glomerular pressure, secondary focal segmental glomerulosclerosis, all of the above or none. So pathophysiology after the kidney donation or when you have a unilateral native nephrectomy, what happened? We have a compensatory mechanism or change, either renal hemodynamic change or glomerular structural change. For the renal hemodynamic change, there is an increased afferent renal plasma flow, lead to the increased single nephron glomerular filtration rate and glomerular hyperfiltration. For the glomerular structural change, there is pathway of cellular regulation. For example, mTOR inhibitors, IL-10 or TGF-beta that lead to glomerular hypertrophy. Both glomerular hyperfiltration and hypertrophy lead to increased intraglomerular pressure and then develop podocyte injury, either glomerulosclerosis or proteinuria. Secondary, FSGS. So again, this is a pathophysiology after living kidney donation that can happen. Not everyone is low risk, but for my talk, I will emphasize on how to mitigate the risk of the secondary FSGS. So in the past, post-donation and ESKD risk, they found that since 2001 until 2012 from this for reference, there is no increased risk of the end-stage kidney disease post-donation compared with a non-donor population. However, over the past decade, there is a more cumulative evidence that risk of end-stage kidney disease after donation is increased compared with a non-donor. For example, in 2014 in Europe, living donor has an increased risk of end-stage kidney disease with a hazard ratio 11. 2014 at the same year, as you can see, living donor has 30.8 per 10,000 compared with 3.9 per 10,000 in the general population to develop end-stage kidney disease. And the most recent one in 2016, as you can see, living kidney donor has up to 5.3 times greater the risk to develop end-stage kidney disease compared with an age-matched non-donor. You can see, again, living donor is not a risk-free. So this comes to the question number 3. In your opinion, which of the following is the best description regarding kidney function of living kidney donor? Again, we remove one kidney. Ideally, GFR lower 50%, but there is a compensatory mechanism that we discussed in the prior slide. Is GFR within 3 to 6 months post-donation, going to be 45 to 50% of pre-donation, and condition is called CKD, or 55 to 60% in non-CKD, or 65 to 70% of pre-donation GFR CKD, 75 to 80% of pre-donation GFR and non-CKD, or this uncertainty either CKD or non-CKD. So in the living kidney donor and risk to develop chronic kidney disease, one, our potential living donor has a unilateral nephrectomy, then new GFR going to be equal 65 to 70% of the pre-donation GFR within 3 to 6 months. The question is, can we declare our living donor to be as chronic kidney disease patient or not? So our group proposed that we should use the term kidney function of the donor or KFD rather than chronic kidney disease in living kidney donor in order to provide, in order to avoid stigma or problem with the insurance issue. And again, our human body can live with one kidney without any symptom of chronic kidney disease. One thing, this is for the pictorial and calculation to make it clear. Pre-donation GFR in general population, let's say around 125 milliliter per minute per 1.73 square meter. After donation, 3 to 6 months, our body gonna have compensatory mechanism, and GFR post-donation gonna be 65 to 70% of the baseline. It's gonna be around 81 to 87 milliliter per minute per square meter. If we grade by GFR by CKD, it's gonna in the area of stage 2 chronic kidney disease. But again, in our opinion, we should not call living donor as chronic kidney disease. This study is a longitudinal study and is shown clearly on the dark line compared with a dashed line. Dashed line is a non-donor. Dark line, as you can see, on the first day of the donation, GFR drop. But as you can see, within the first 5 years, actually our donor have increased in GFR around 1 milliliter per minute per year, and it's plateau around 5 years post-donation, compared with a non-donor counterpart that is a gradually drop in the GFR every year. So now, apart from risk of develop chronic kidney disease, as we discussed, living donor is increased risk for proteinuria. And this study, these two study meta-analysis and show that compared to non-donor, living donor has a higher risk to develop proteinuria from 24-hour urine collection or microalbuminuria from the lower figure. In addition, hypertension is a one potential long-term medical complication of living kidney donor. And this is a longitudinal study. Again, it's a big study. It concluded hypertension developed up to 4%, 10%, or even up to 51% at 5, 10, and 40 years post-donation respectively. But usually, again, as I discussed, living kidney donor usually around in the middle age. They may live up to 40 more years and develop hypertension around 50%. But in general, it's gonna end up with around 10% risk in 10 year post-donation, 10-10. Now, this systematic review and meta-analysis show again for the living donor and risk to develop hypertension. Yes, it's around 5 millimeter of mercury or around less than 5 millimeter of mercury of systolic and diastolic blood pressure respectively after donation compared to non-donor. Last thing for the woman, the question come all the time for the childbearing age woman. Should they pregnant first and then donate on the left-hand side, or should they donate first and then become pregnant? On the first scenario, if they would like to pregnant first and then donate. So hypertensive disorder in pregnancy can happen, including gestational hypertension, preeclampsia, or eclampsia, depend on their risk of the their risk of pregnancy. For the long-term risk after donation, yes, there's a slightly increased risk for end-stage kidney disease. On the right-hand side, if they would like to donate first and then pregnancy. So basically, for the medical complication in the past stage, no support data that if they donate and then pregnant, living kidney donor gonna increase risk to develop hypertension, proteinuria, GFR change, or urine sediment abnormality due to hyperfiltration. But in the later on study, they found to have a increased risk of gestational hypertension and preeclampsia. Other risk is maybe from the thromboembolic phenomenon from the estrogen exposure, because they have to use a birth control pill after donation and then pregnancy. And for the non-pregnancy period, when they donate, there is the lag time between after donation approval until post-donation recovery. This study again, systematic review and meta-analysis to determine the risk of gestational diabetes and preeclampsia in kidney donation. In summary, gestational hypertension or preeclampsia in living kidney donor compared to the matched non-donor, there is a increased risk around 11% compared to 5% of the living donor versus non-donor with an odds ratio of 2.4 with statistically significant. However, the most recent study in the pregnancy after living kidney donor is another systematic review. So this includes 16 original articles examining the complication in post-donation pregnancy, meaning that almost 1,400 female donors who undergo pregnancy. So they donate first and then pregnancy. They found an absolute risk of preeclampsia compared to the general population. For the pre-donation pregnancy, meaning that they're pregnant first and then donate. The risk of preeclampsia is less than 4%, which is a less than general population. On the other hand, if they donate first and then pregnant, the risk is around 4 to 10%, but the risk is still the same as the general population for the preeclampsia risk. And the risk of adverse fetal and non-fetal outcome is not different between post-donation and pre-donation pregnancy. So in this study, it's pretty reassured that regardless we're gonna do pre-donation first or post-donation first and then pregnant or pregnancy first, the risk for the donation first, yes, increase more for the pregnancy-induced hypertension or preeclampsia, but it's not much different compared to the general population. Another interesting long-term complication of the living donor come up with this original study, cancer risk in living kidney donor. So they include almost 85,000 living kidney donor in the United States from 1995 to 2017, and it's linked to the cancer registry data. The comparison is up to 47,000 Adventist Health Study 2 participants, which this kind of participant eat a healthy lifestyle, just for your notice. And the study result found that 2,800 cancer in the donor with a standard incidence ratio of 0.79. And there's a 46 specified cancer site, which is pretty similar to general population. And they follow up the population in 7 years post-donation, but there is an increase in incidence of just 2 cancer. As you can guess, kidney cancer. And another thing is colorectal cancer. If we deep down in more studies, a busy slide, I would like to focus on the 2 cancer. Again, they compare between the living kidney donor versus Adventist Health Study participant for the cancer incidence risk. For the colorectal and kidney cancer, colorectal cancer after follow-up 7 years, adjust incidence rate ratio is up to almost 2 times higher the risk with statistically significant. For the kidney cancer, after follow-up 7 years as well, is up to 2.97 times higher the risk. So why these 2 cancer increase risk in the living donor? For the colorectal cancer, they thought that maybe dietary change or dietary pattern in the living donor. Typical US diet is different from the diet that Adventist population take it. For the kidney cancer, the explanation is that in the living kidney donor, this is a hyperfiltration-related hemodynamic change that can induce or include a proteinuria, hypertension, and end-stage kidney disease. And these 3 factors is a known risk factor for kidney cancer in the epidemiology study. So in summary, for the first part of my talk, what is a possible potential long-term medical complication in the living kidney donor? Chronic kidney disease, end-stage kidney disease, proteinuria, hypertension, gestational hypertension, and preeclampsia, and the last thing, some type of cancer, colorectal and kidney cancer. But again, for the interpretation, have to be careful because that study is compare living donor compare with Adventist participant, which is a eat healthy diet, not the general population. So now I come up to almost the last part of my talk, and this my emphasis is how to manage post-donation, and I will emphasize for the dietary intervention to increase the living kidney donor and improve the long-term outcome and mitigate the long-term complication of the living kidney donor. So we can divide into pre-donation, pre-operative, and post-donation, but I'm going to emphasize on the pre and post-donation period. So what is the most common question that potential living kidney donors or even post-donation donor ask you? Just thinking about it, but I have an answer in my mind, and I believe our audience also has a question in your mind as well. I think they ask us, what should I eat, either before donation or after donation? So what is the preventive strategy for the living kidney donor? We can divide into non-pharmacologic and pharmacologic intervention. The non-pharmacologic including low protein diet, low sodium diet, weight control, hydration adequately, smoking cessation, physical activity after nephrectomy. For the pharmacologic intervention, including blood pressure control, proteinuria management, and anti-proteinuric effect. For the interest of time and for the purpose of my talk, I will emphasize on the non-pharmacologic intervention for the first three bullets: low protein diet, low dietary sodium intake, and weight control. So let's start about the dietary protein intake. So when our patient asks us, they ask us two things: how much and what kind of protein, or what is the quantity and quality of the protein they should take. Okay, let's emphasize about high protein diet. Why is lead to or is a risk factor for chronic kidney disease. So it increase afferent arteriolar vasodilation, and initially it's actually protein diet increase GFR, but in the long term, increased GMR, increased glomerular hyperfiltration, intraglomerular pressure, and tuberoglomerular damage, and lead to chronic kidney disease. And this slide is a pretty nice an epidemiology study. It showed that the correlation between GFR on the y-axis and overnight urine urea, which represent how much 24-hour urine, so how much 24-hour dietary protein intake. As you can see, if the patient has overnight urine urea more than 5 milligram per hour, beyond this red line, there is a hyperfiltration or increase in GFR, which we don't need it in our kidney donor because it can cause increased intraglomerular pressure and chronic kidney disease later on. And when we translate, what does it mean? Urine urea nitrogen 5.19 milligram per hour is translated to be equivalent or pretty similar to recommended daily allowance of protein intake around 0.8 gram per kilo per day. So it's come up with how much protein intake. So for the KDOQI guideline 2020, which is update for the chronic kidney disease stage 3 to 5, who has a metabolically stable, it cannot compare with our living donor, but it may be extrapolate. They recommend around 0.55 to 0.6 gram per kilo per day. For our donation, we don't know, but per the prior slide, maybe around 0.8 to not more than 1 gram of protein per kilo per day may be reasonable in our opinion, in our group opinion. Now let's talk about the source of protein and risk to develop chronic kidney disease progression. So this study, they compare between the population who eat red meat and processed meat. As you can see for the black line, the higher red meat intake, the higher hazard ratio to develop chronic kidney disease progression. On the flip side, if the patient eat plant-based protein, for example, in this study, a legume, there is a inverse or negative correlation between the amount of plant-based protein intake and risk to develop chronic kidney disease progression. It seems that the plant-based is a protective effect for the chronic kidney disease in general population. What about dietary sodium intake? We know that the sodium, why sodium lead to at risk to develop chronic kidney disease progression. Again, high dietary sodium intake can directly cause kidney injury or indirect kidney injury. For the direct is increased glomerular hyperfiltration, intraglomerular pressure, and glomerulotubular damage. For the indirect renal injury, it leads to hypertension, and both direct and indirect associated with the increased risk of a chronic kidney disease progression. So this systematic review and meta-analysis show that high dietary sodium intake increased risk of GFR or hyperfiltration, which we don't want in our living kidney donor. And also high sodium intake increased risk to develop proteinuria. Now, dietary sodium intake and chronic kidney disease, how much that we're gonna counseling our living kidney donor. This is interesting study. They divide study population into 4 quartile, 1 to 4, depending on daily sodium intake. The lowest one is quartile 1 and the highest one is quartile 4. As you can see, quartile 1 has around 2 gram of sodium per day, and quartile 3 has protein intake, sodium intake 3 to 4 gram per day. You can see the risk for the CKD progression compared with the quartile 1 is the highest in quartile 3, but not quartile 4 and quartile 2. So what we're going to conclude with the thought that the incidence of chronic kidney disease was significantly longer in quartile 3 group than quartile 1 group. Sorry, not longer, this is higher in quartile 3 group than quartile 1 group. Meaning that if we're going to take lower sodium or higher sodium, it should be okay. But if we take around 3 to 4 gram, it's a higher. So without much evidence how much sodium intake, our group thought that maybe less than 4 gram per day may be reasonable. So when we talk about hypertension, it's hard to skip about the sodium and blood pressure. And hypertension in the living kidney donor, we know that is one of the most common modifiable risk factor for cardiovascular in general population. And hypertension prevention should mitigate the risk of chronic kidney disease and cardiovascular disease in the living donor. Non-pharmacologic intervention should be universally implemented, and dietary sodium intake 2 to 2.3 gram per day in general population is recommended by American Heart Association. And what about in the living donor? We don't know. So our center tried to do a pilot study. It's entitled Dietary Sodium Intake and Blood Pressure in Living Kidney Donor. It's a pilot single center crossover, single blind randomized controlled trial or split trial. So our hypothesis is low versus high dietary sodium intake can control systolic and diastolic hypertension within the lower level, and lower the low sodium intake should lower the risk of develop hypertension, worsening kidney function, and developing proteinuria. And specific aim 1 is to determine the feasibility of the trial study design, and aim 2 is to evaluate the effect of low dietary sodium intake on systolic and diastolic blood pressure in living kidney donor. Aim 3 to evaluate the effect of low dietary sodium intake on the changes in eGFR in living kidney donor. And the last thing is to evaluate the effect of low dietary sodium intake on the change in proteinuria in living kidney donor. So the study design is a pilot single center crossover single blind randomized control trial. Because of the nature of the study, the patient dietitian and research coordinator is unblind. Only the principal investigator is blind. And we still ongoing enroll now and plan to follow up in 12-week post randomization. So study population is a consecutive living kidney donor who donate the kidney at our UCI Kidney Transplant Center and meets the following inclusion and exclusion criteria. The easy inclusion criteria: adults 18 or beyond 18 years old, more than 5 months but less than 1 year, and agree to perform procedure as per study protocol that I'm going to show you in the subsequent slide. For the exclusion criteria is a non-adherent with a dietary sodium intake as per study protocol, diagnosed with hypertension or on antihypertensive medication before donation. Albumin creatinine ratio more than 1 gram per day within 20 weeks post donation by either spot urine or 24-hour urine collection, and eGFR by CKD-AP less than 20 milliliters per minute per 1.73 square meter, requiring dialysis post donation. Medication that cause hypertension, such as NSAID or oral contraceptive pill, and drinking caffeine or cigarette smoking. This is a study procedure. As you can see, we have a run-in period for 4 weeks, and then at the time 0, we again a run-in period. Every patient takes sodium 3 to 3.5 gram per day, and then we randomize the patient into group A, low dietary sodium intake, defined by having sodium intake 2 to 2.3 gram per day as per dietitian guidance. For the group B, high dietary sodium intake 4 to 6 gram. After 4 weeks, every patient come to breaking period. Everyone take sodium 3 to 3.5 gram per day, and then we cross over from the group A become group B, and group B become group A. Follow up for 4 more weeks, and then this is a study procedure for the pre-randomization. As you can see, again, we have a run-in period, randomization, pre-crossover, washout, and post-crossover. And we have a screening period. We use urine chemistry and 24-hour urine collection, every single visit, 24-hour ABPM, physical exam, and patient report outcome, including SF-36 form. And the intervention is adherent by our dietitian. Again, our dietitian will guide every single patient every 2 weeks by the in-person or maybe Zoom appointment. And dietary sodium intake by dietitian as well, and adverse event we follow up post randomization. And if anyone or you know someone who eligible in our study, again, living kidney donor who would like to participate in our study, please contact us or contact me. So control diets are using a single macro or micronutrient. For example, you ask the patient, you should eat protein, how much and what kind of protein, or you should eat sodium like this. It's not quite practical because when the patient eat food, they eat protein, fat, carbohydrate, sweet, fatty food, or carb. So dietary pattern may be the more practical to advise the patient for dietary intake. And this is a summary for the plant-based protein and the dietary pattern. As you can see, the healthy diet going to be DASH, Med diet, or Mediterranean diet, or vegetarian diet. There is some overlap. For example, DASH, there is a seed nut. Med diet or Mediterranean diet may emphasize more on the fruit or wine. And the vegan, as you can see, there's a vegetable and a fish or poultry in the overlap. And as you can see, the Mediterranean diet seems to be associated with mitigate the risk of decline in kidney function in the living kidney donor. And this one I provide a reference that you can study by yourself. But overall, Mediterranean diet seems to be quite the best. Another interesting study for the protein and calorie restriction may improve outcome in the living kidney donor and kidney transplant recipient. In summary, if living donor restrict protein and calorie diet, from the post-donation day to up to month 1, kidney function of donor was significantly better compared to the control group. So I would like to demonstrate the real life for our patient, how we counseling the patient in terms of the diet to mitigate the long-term risk for both pre-donation and post-donation. Let's because sometimes when we ask the patient to have low dietary sodium intake or protein intake, yes, the patient understand, but in practical or how to implement is difficult. So let's start with the patient number one. This is a 60-year-old woman would like to donate to kidney to her cousin. This is her anthropometry or her weight is 85, height 72, and body surface area 2 and BMI 28. This count as overweight. So she have a total 24-hour urine collection in order to determine the creatinine clearance and determine the eligibility of a living kidney donor. In our center, we also emphasize on the diet. So we check 24-hour urine sodium and urea for every single patient in order to calculate back how much dietary sodium and how much dietary protein intake respectively. So when she has a 24-hour urine collection, the first time you can see in June 2024, she have dietary protein intake 0.7 gram per kilo per day, which is not bad. I will go around 0.8 to 1, less than 1 gram per kilo per day, if you can recall. And dietary sodium intake up to 3.6 gram per day. Again, goal is around 2 to 2.3 gram per American heart. So we found that the first time the patient has an under collection. So we asked the patient to redo 24-hour urine collection again around 2 weeks later. And the patient kindly enough do it again. Protein intake pretty much the same, 0.78 gram per kilo per day. But as you can see on the highlight, the red color, dietary sodium intake up to 5.3 gram per day is pretty high and we a little bit concerning. Because as you can see from the previous pathophysiology, increased dietary sodium intake may later on increase risk of hypertension and direct injury to the kidney and lead to the associated with chronic kidney disease progression. Obviously, we would like, and again for second time, the patient has a GFR that eligible for the living kidney donor for in terms of a creatinine clearance. But in terms of the long-term risk, we would like it to be optimized for the dietary counseling. So we ask the patient to check the third time, 24-hour urine collection. But before the third time, we would like to make sure that the patient follow our dietary regimen, meaning the low dietary protein and low dietary sodium. So we before the third collection, we ask the patient to do this one 3-day food diary, which is we use a tool, which is an online tool, not just a pen and paper. The online tool is called ASA or self-assessment 24 hour, which I'm gonna show you in the subsequent slide. She do it in the end of July 2024, and this tool is pretty impressive because after the patient collect 3-day food diary, and it's the website automatically calculate back how much protein and how much sodium intake, and she eat even lower protein 0.66 and sodium intake 2.6, which is meaning that she comply with our dietary advice. So after that, she followed by the third 24-hour urine collection around 10 days later. Protein, she accept that she didn't control much, but the sodium she still control the same and even better than the dietary food recall. As promised, what is the ASA? ASA is acronym from the Automated Self-Administered 24-hour Dietary Assessment Tool, is funded by NIH, run by National Cancer Institute to assess the daily food intake. And this tool can perform by using dietary food diary, as I showed in the prior slide, or can use as a tool to determine dietary recall. And there's a function that is pretty nice, and you can create the pattern like a 1 day, 2 day, 3 day, or how many days food diary, and email the patient the link, and the patient can record the link. The good thing that these are almost 13 million food entry that the patient can search. They don't have, and if they cannot search the food item, they can type the food item, and This is pretty detailed because if every single food item, the program asks the patient to put how many bottle of the drink, how many ounce of the salmon, for example, that the patient eats in each meal. So this is a pre-donation. What about post-donation? We have a patient number 2, 50-year-old overweight man, have an acquired solitary kidney secondary to left native nephrectomy from a living kidney donation in April. And he come to the 6-month post-donation follow-up. The patient is a muscular man, work out in the gym 2 hours a day. Weight is 86, height 183 centimeter, BMI 25. It's a little bit overweight, but seem to be muscular. The patient asked me, can he still continue whey protein, protein powder, protein bar, and high protein diet? I asked him, so again, this is a 24-hour urine collection from the pre-donation that the patient collect for us. And again, we collect urine urea and calculate back how much dietary protein intake, and the patient eat 0.9, which is quite totally acceptable for us. And dietary sodium intake 3,000. So before donation, we asked him to minimize the dietary sodium intake. So the answer is yes. If he still continue have a dietary protein intake like this, he can happy to go to the gym and have a protein that he wants. But we also, again, as we talk about not only quantity, the quality of the protein, we still emphasize the natural food protein and avoid red meat and avoid non-natural like a protein bar or whey protein or protein powder. Again, this is a benefit of the uh, tool, like a 24-hour urine collection. And obviously after donation, we send the patient ASA24, which is an online tool that I show you from the first patient, to have him check a 3-day food diary to remind himself how much he eat protein, how much he eats sodium. So the last thing that I would like to discuss about pre and post donation is a weight, because it's kind of the barrier to our patient to get a living donor, and in the long term it can lead to the or associated with a chronic kidney disease in the long term. So living donor, obese and non-obese, compared with the non-obese in the black line, obese pre-donation increased risk to develop chronic end-stage kidney disease with a hazard ratio up to 1.86 times. And this is a long-term follow-up up to 20 years. So the complication for the pre-donation obesity for the short term is for the BMI greater than 30 is increased operative time, is a logistic for the surgeon, but there's no associated with the increased warm ischemic time, blood loss, or length of stay. For the long term, is no association between the BMI and death over 12 years follow-up period by using US registry data, which is nice. However, there's an increase in cardiovascular risk up to 1.03, which is minimum, but not all-cause mortality. So again, pre-donation obesity in either way increased risk for short-term and the long-term. So this is a viewpoint, the bariatric surgery for the prospective living kidney donor with obesity. So benefit for the bariatric surgery for the potential living donor, for the recipient obviously is good for they receive good quality kidney and access the kidney transplantation. But for the donor, there is a decreased risk of end-stage kidney disease when they lose weight, and decrease metabolic disease including diabetes, hypertension, and hyperlipidemia. So the goal of BMI 30 kilogram per square meter less than or equal seems to be reasonable. But again, in the United States, BMI 30 may be very common, and some center included us try to individualize and still accept the potential living donor that greater than 30 kilogram per square meter, but it depends on our assessment and long-term risk for the metabolic complication. So over the past years, there is a pharmacologic therapy for the pre-donation obesity. And this is a viewpoint that brings for the discussion for today about the anti-obesity pharmacotherapy to facilitate living kidney donation. You can see there is both FDA approved for the anti-diabetic medication, for example, Wegovy or semaglutide, but the patient may have to end up with a pay out of pocket. There is an off-label use, for example, or Ozempic or Rybelsus. This again, out of pocket still high as well. So in this study, in the viewpoint, yes, if the patient who would like to donate the kidney has obesity, they can get the anti-obesity medication to lower the obesity. But the obesity is long-term. It can rebound for the post-donation and require the long-term follow-up. It's come up with a cost of not only medication, but the cost for the follow-up, including specialist or primary care doctor, and come up with issue of the sustainability in terms of the long-term obesity management as discussed. And the last thing is the data compared to the non-obese living donor and non-donor are required. So come up with almost a last slide for the future direction of the nutrition-related management in the living kidney donor. For the pre-donation that we discussed about the bariatric surgery or pharmacology, including anti-obesity medication, and also that we emphasize on this talk is a non-pharmacologic management by dietary intervention, including low protein and low sodium diet. For the operative is not much evident. Again, we come from the bariatric surgery and anti-obesity medication management from the pre-donation. Post-donation, again, emphasize on the dietary intervention to prevent hypertension, proteinuria by low protein, low sodium diet. Cancer screening still in the controversial, again, colorectal and kidney cancer, but the control group may not quite equal. In pharmacologic intervention, anti-diabetic medication that require long-term follow-up. And the last thing that we'd like to stimulate our thought and the policy in terms of the should we follow up our living donor who is a hero beyond the 2-year post-donation or not, or just let them go to see primary care doctor or if they would like to be more specialized, see nephrologist. Some, not all, but pretty high number of our living donor that don't have primary care doctor, which is some kind of worrisome as well. If we're gonna let our hero or living donor not have anyone to follow up beyond 2 years post donation. So last slide, long-term outcome, the question from the transplant perspective is including 3 factor: patient factor, stakeholder, and provider. For the patient factor, living kidney donor eligibility that they're interested, whether they are eligible or not, they need to undergo bariatric surgery on anti-obesity medication or not. They're also concerned about long-term and short-term complication. Stakeholder, including the insurance and expense that I discussed about, should we, as a transplant provider, see the patient beyond 2 years? And the last thing for the aspect of provider, what is that we interested in the barrier for the living kidney donation, surveillance and prevention for the complication and allocation organ system, including kidney pair donation that we didn't talk in my talk today. So overall, we've come to the outcomes, to the long-term outcomes. Last thing, I like this picture because don't forget living donor kidney transplant versus deceased donor kidney transplant. The recipient who receive a living donor kidney transplant, they don't have to wait and the shorten transplant access. Another thing, living donor kidney transplant, when we do it one case, is similar to we give one deceased donor kidney back to the wait list pool. So in conclusion, the kidney transplantation is a treatment of choice for suitable advanced chronic kidney disease and end-stage kidney disease patients. Some barriers for kidney transplantation may limit transplant access, And living donor kidney transplantation is one of the strategies to overcome this barrier. Epidemiology data have shown long-term risk after living kidney donor, including chronic kidney disease, end-stage kidney disease, hypertension, preeclampsia, and some types of cancer. But the evidence needs to be justified. Anti-obesity medications may increase the possibility of donation, but long-term follow-up is required. And it may come up with an ethical issue in terms of the follow-up, financial, for example. Preventive strategy, especially non-pharmacologic interventions such as dietary intervention, should be utilized universally in living kidney donor. And at the end, I would like to acknowledge our UCI kidney pancreas transplant team, including the leadership, nurse practitioner, coordinator, transplant pharmacist, dietitian, transplant social worker, and administrator. UCI Division of Nephrology leadership, UCI Clinical and Research Fellow, Center for Clinical Research, ICTH, Waste Management Program, Department of Medicine for grant support. And last but not least, I would like to acknowledge our patients who provide help to our patient, which is recipient and is our hero, and also stimulate us to have a clinical study and research to improve the outcome for the transplant field and living kidney donor field. And this is my reference. And again, this is our transplant team many years ago, 100 plus milestone, but now it's 200 plus milestone. And thank you very much for your attention. If you have any question, please feel free to email me. And I appreciate your comment and advice. Thank you very much.